Dear colleagues, a very warm welcome to this Geistlich webinar. I'm very excited to being able to have the webinar, and it's kind of a new form, but we have all gotten used to it, I think, and I will be talking about tooth extraction and subsequent implant placement challenges and opportunities. Let's have a look at the young patient that has had a bike accident. Her central incisors, upper central incisors, need to be extracted, and let's have a look what's going to happen on the biological level to the bone and the soft tissue. So we have to extract these central incisors. There is on the right-hand side already an extraction has taken place. You can see the healing and you can see a volume shrinkage. Now the left incisor has to have been extracted, and you see the alveolus and the wound that is in place at the moment. Here you do see a screenshot of a CBCT, and this is kind of a rendering where you can see what's going to happen to the volume on the level of the bone. And I think it's quite impressive when you look actually, especially at the buccal part of the alveolus, and you see that we do have to expect a lot of shrinkage after tooth extraction. This can amount to up to 50%, especially in the first few weeks and months after tooth extraction. And this can lead to some more difficult situations when wanting to restore the patients. So let's have a look at this patient a few years later. She would like to have fixed teeth. She has been going with a provisional, a removable provisional. Now she has to reach for fixed teeth again. And this is the situation we look at. So this is after final healing of the site. You do see, especially at the buccal aspect, we have lost a lot of volume, not only on the level of the bone, but also on the level of the soft tissues. When we elevate the flap, because we have planned implant placement, we do see that there is not much of the bony ridge present. So what do we have to do in this case? We have to do a primary bone augmentation in order to be able to then place implants which can reach primary stability. So we do, or in this case, a primary bone augmentation was performed from the mental region. There was an additional GBR performed, and then after a while it is possible to place the implants. But as you can tell, this is a rather invasive treatment. So the question that we are asking ourselves, or that maybe also the patients ask us as treating dentists, what can we do against alveolar ridge resorption? And how can we present at least a big part of the resorption? How can we become less invasive for the benefit of our patients? So let's look at another case. This is another patient. She was also quite young when she had an accident. She has also lost her two central upper incisors, and a different approach has been chosen in this case. So a bone substitute material has been placed into the alveoli after tooth extraction, and then a soft tissue punch technique has been applied in this case with autologous material harvested from the patient's palate. Here you see the pictures after healing and suture removal. It's a very nice healing. The tissues are very well integrated. And this is the pictures, the clinical pictures after the full healing of the site. And you can already now see a big difference compared to the case that we have seen just before. Now in this case, when we do the flap elevation, you can see there is still quite some ridge width present. It will be possible to place implants in the desired prosthetically correct position. And you can see here it has been planned previously, and the implants have been placed using a guide. You see, there is really some buccal bone still in place, which is quite nice when we want to place implants. We still have the possibility to do a GBR procedure in this case, but for sure we don't need a primary bone augmentation. So if we compare these two cases, on the left you have the first girl that had an accident where spontaneous healing had been awaited, and on the right side you see that alveolar ridge preservation has been performed. And you see that clinically on both the hard and the soft tissue level, there is quite a difference. So if I would ask you as a patient, which option would you like to go, or which option would you like to choose, you would probably all, if you were the patient or if you are also the treating dentist, want to choose the right or the second clinical case that I have showed you. So what is really important and what I want to express is that it is really important that when we plan a tooth extraction or when tooth extraction is imminent, we really have to have a plan. So we have to take the right decision for the patient and for the clinical situation. So when we extract the tooth, we need to know what the next steps are going to be. This is really important. So let's have a look at the biology and at the anatomy quickly. We do have the alveolar process that lies on top of the basal bone. The alveolar process is the part of both the maxilla and the mandible that supports the socket of the teeth. So the alveolar process is built by the tooth eruption. And when the teeth are going to be extracted, we will lose part of the alveolar process that lies on top of the basal bone. So what we always aim for when we have to do a tooth extraction is to go for an atraumatic extraction, because we want to preserve as much bone and as much soft tissue as is possible. So when we look at the biology and a bit also at the histology, we know that we have the bundle bone at the buccal aspect. You see on the histological slides at the bottom right corner, the bundle bone is to your right. And you see what's going to happen when we do an extraction. We will have some osteoclastic activity, mainly at the buccal aspect. So we do have to expect some resorption, and it's going to be more, there's going to be more resorption at the buccal aspect compared to the oral aspect or the palatal aspect. We do have to expect some vertical, but also some horizontal resorption. This will then result in a reduction in ridge width, which has to be taken in account when later on planning a substitution of the tooth of the single or the multiple site. So another thing is also when I talk about atraumatic extraction, it's not only the extraction of the tooth, but also it's the handling of the soft tissues. We always aim at not doing a mucoperiosteal flap. So we try aiming at a flapless extraction of a tooth. Because when we have to do a flap, when we have to relieve a flap, then we will have reduced blood supply, which will also have a detrimental effect on the underlying hard tissues. So this is really important to keep in mind. When we look at spontaneous healing, and some groups have looked at this in humans, here we have a look at the systematic review, which concluded 20 different studies, and they have assessed the magnitude both in a horizontal and in a vertical dimension within single tooth sites, and have followed these patients for 12 months. So what is going to happen on horizontal change? You see the picture, the clinical picture on the left side, just after tooth extraction, and then again after 6 months. This is kind of half time for this study on the right clinical picture. And they have seen that they had a mean change in horizontal ridge width of up to 3.8 millimeters. In percent, it's between 30 and 60% of the whole ridge width was lost over 12 months. Let's look at the vertical aspect, the vertical change. You see left again just after tooth extraction and on your right side after the healing procedure. So here they have experienced 1.2 millimeters in vertical loss, which is between 10 and 20% of the ridge height. So the resorption is was more prominent at the buccal. You can also see from these occlusal pictures when you compare the left and the right picture. It is more prominent in the anterior compared to the posterior region, and the resorption is more rapid, so you will experience more reduction within the first 3 to 6 months, and then the reduction will level out. So to conclude, if you look at the alveolus on your left side, you will have some resorption both in the horizontal and in the vertical. In the horizontal, more than 1 millimeter, and in the vertical, up to almost 4 millimeters. And in percentage, volume-wise, over 6 months, horizontal between 30 and 60%, and vertical between 10 and 20% of the original ridge width or height. So this is quite a lot. This is what you have to expect when you do await spontaneous healing. So the primary aim that we have is we want to reduce bone resorption and we want to save the alveolar bone. So this is the primary aim. So the decisions before tooth extractions are various, and you can see on this scheme that you can either go for spontaneous healing depending on the site, on the aesthetic importance, maybe on the wishes of the patient, maybe on the age of the patient. You could but also go for an immediate implant placement with or without GBR procedure and or soft tissue augmentation. We will come to this later on. Or you could choose an alveolar ridge preservation, where you have a lot of different techniques you can go for. You see here some of the possible techniques for ARP. You can either go for soft tissue preservation, where you would have a bone augmentation and a soft tissue, or you could have a soft tissue substitute. You could even do flapless ridge preservation or open ridge preservation. So with these clinical pictures of a case that I have treated, I would like to ask some questions, and we will come back to this case during the presentation. Can we prevent the ridge from resorbing? We have just seen that we have to expect a lot of resorption when we go for spontaneous healing, but maybe there are some techniques that we can use in order to prevent the ridge from resorbing and have a better outcome when starting the final treatment. So on these pictures, you see I had to extract the right central upper incisor, and after healing, after 6 months healing on the right side, you see I have not lost a lot at the buccal aspect. I have lost a bit. You can see in the soft tissues a slight invagination at the buccal aspect, but in general the ridge contour is quite the same as it was on the left side before the extraction of tooth 1-1. So let's look at ridge preservation and some principle and treatment options when aiming at implant placement later on. We can either do immediate implant placement, so do an extraction and place the implant in the same appointment. We can do early implant placement. So we could await soft tissue healing, and this would mean we would wait for 4 to 8 weeks for the healing of the site. We could then also go for delayed implant placement, where we would wait between 12 and 16 weeks. Here we would await a partial hard tissue healing, so a partial bone healing is awaited, or we could aim for a late implant placement, where we would wait, or we would leave the site to heal for 6 months or even longer. Here we would then have a complete hard tissue healing when we place the implant. So what are the options here? Options for implant placement after tooth extraction. To your left in pink, at the time of tooth extraction, you see immediate implant placement. This would be type 1, would be at the time or a few days after tooth extraction with or without augmentation procedures. You could go for type or option number 2 and also at the time of tooth extraction do an alveolar ridge preservation, ARP, and then go for a type 3 or type 4 implant placement, again with or without bone augmentation procedures. What you could also do, you could not do a ridge preservation procedure and go for type 2, 3 or 4 implant placement. So you could either wait for soft tissue healing, partial bone healing, or full hard tissue healing. So let's look at these timings of implant placement. Type 1, as I said, would be the immediate implant placement. Type 2 would be the early implant placement. Type 3 is called delayed implant placement, and type 4, where we would wait for 6 months for the healing of the ridge, would be the late implant placement. So first let's look at type 1 implant placement, and let's ask the questions, could we maybe prevent bone resorption by placing an immediate implant right into the socket? We know on the level of the hard tissues, we do have to expect a vertical and a horizontal resorption, and the location of the resorption is more to the buccal than to the lingual or the palatal side. The same also goes for the soft tissues. It's not only the resorption that is happening on the hard tissue level, but also on the soft tissue level. So we do lose some soft tissue contour, and the biotype also has an influence on the behavior of the soft tissues. So what could be possible advantages of immediate implant placement? First of all, maybe it's the patient that would like to have a quicker treatment, the patient that would ask for a tooth as soon as possible. So we would have on one side the patient benefits. We will probably end up with a shorter treatment time. We will maybe end up with a more cost-efficient treatment when we place an immediate implant, because we don't need so many appointments. We can do a lot of things at the same time. But there are also quite some disadvantages when placing immediate implants. It is much more difficult than placing an implant in a healed site. So it is difficult to reach primary stability, especially if you look at the site in these clinical pictures. You see you have a huge alveolus, and it's really difficult to place your implant in a stable and exact position where you have planned your implant. So the positioning of the implant is really a challenge in most of these cases. Then maybe you don't have a lot of bone present, especially here in the middle picture. So you see you have a very big alveolus, and it's really difficult to place your implant. There is not a lot of soft tissue left, because when you do a tooth extraction, there is no soft tissue that will cover the alveolus. So it will be more difficult to close the wound or to do the suturing. It is more difficult in planning these cases, and it is, for most of us, for me at least, I can say, much more stressful when doing the procedure. So we had the idea of maybe being able to prevent resorption on both the hard and the soft tissue level when placing an immediate implant. We know when we wait for spontaneous healing, we lose up to 50% at the buccal aspect of the volume. So we could place an implant that really fits into the alveolus and that touches the bone at the buccal and at the palatal aspect. And then maybe we could present the resorption. Let's look at some clinical data that we have for this type of treatment. Jen and co-workers have treated 30 patients in a prospective clinical study with single implant sites, and they have evaluated the healing of these defects when placing immediate implants into fresh extraction sites. So what did they see after 6 months? They did see vertical reductions in all of the cases, whether they have used bone substitute alone, bone substitute in combination with a membrane, or whether they have just placed the implant in the extraction site. The vertical defect reduction reached up to 80% of the volume. The horizontal defect reduction showed almost the same number, also up to 80%. What about the horizontal resorption? It reached up to 50%. It would be, or it is the same as if we would leave the alveolus for spontaneous healing. So it seems, or it shows, this study shows that there is no difference whether we do an extraction, leave the extraction site for spontaneous healing, or when we place an implant. Let's look at another study by Botticelli and co-workers, also a human study, a clinical study in 18 patients with more than 20 teeth, also single tooth sites and immediate implant placements. They have looked at alterations also in ridge width, and they did see that they had new bone formation from the inside, so from the palatal aspect, and substantial bone resorption at the buccal aspect. And again here they did see buccal bone resorption with up to 55-56%. So the idea would be very good to being able to place an immediate implant and not have the bone resorption, but as you see here from these results, from these clinical studies, the bone resorption will still happen even though an implant is placed. When a guided bone procedure is done at the time of implant placement, which you see at the bottom line, then the resorption can be a bit reduced. It will still have between 15 and 20% of volume loss in these cases. So we cannot prevent bone resorption when placing immediate implants. Let's look at some data for immediate or delayed implant. So immediate type 1 versus delayed implant type 3, where we would await partial hard tissue healing. We would await healing for 3 to 4 months and then place implants. Jan Kosin and his group, they have looked at this and they have performed a systematic review and a meta-analysis comparing these two types of timing of implant placement in single sites. So they have included RCTs and non-randomized but controlled studies with at least 1 year follow-up. What did they find? They did find 3 RCTs and 5 non-randomized studies with more than 470 implants. with a follow-up between 12 and 96 months, so quite long follow-ups. And they did see similar probing depth around the placed implants and similar aesthetic outcomes when comparing these two types of timing for implant placement. What they did see as well was a significantly lower implant survival in the immediate implant placement group, with 94.9, so almost 95% of implant survival compared to almost 99% for the type 3 implant placement. And all of these implant losses, implant failures, were early implant failures. So this is quite a difference between these two types of implant timing. When looking at some other outcomes of this systematic review, regarding marginal bone loss, they said the results were conflicting and highly biased. The soft tissue recession was underreported, and also the data was highly biased, and the PROMs were also underreported. But the most important outcome is for you to know that the risk for early implant loss is much higher when you place immediate implants compared to placing delayed implants. So the practical implications they have suggested are that you as a clinician should outweigh the benefits of placing an immediate implant against the higher risk of an early implant loss. This is probably the most important outcome of these systematic reviews, and when choosing the time of implant placement when a tooth extraction has to be performed. So one more thing is that you have to consider that immediate implant placement carries an additional risk of 4% excess implant loss. And grafting is an integral component when placing immediate implants. So if you do plan to place an immediate implant, you will always have to do a grafting, whether it's bone grafting or additional soft tissue grafting. What about the aesthetic outcomes of these types of implants? When we look at this clinical picture, it looks quite nice. But when we look at the implant site, which you see on the X-ray, it's quite a disaster. So what about the soft tissue preservation and the pink aesthetics at single implants, single immediate implants? Again, a study by Jan Cosin and co-workers, 1-year results in this case. They have placed single implants in aesthetic sites in 22 patients. All had a thick gingival biotype and an intact buccal bone lamella. This is really quite important. They performed flapless extraction and implant surgery at the same time. They did a socket grafting after having placed the implant, and they provisionalized the implants without occlusal loading. What did they do? They recalled the patients after every 3 months, and after the first 3 months follow-up, they had 5 cases that had major alveolar process remodeling, and they had 2 clinical cases with advanced midfacial recession. What did they then do? In all of these 7 clinical cases, they did a soft tissue graft, an autologous soft tissue graft harvested from the palate, and thus were able to improve the pink aesthetic score. Then they recalled these patients, and they have published also the 5-year results of this prospective clinical study. And this is now really interesting to see what they experienced or what they measured in these patients. Still, they had 3 implants, 3 patients with advanced midfacial recession, resulting in more than 1 millimeter of buccal recession. in an aesthetic single site after 5 years. All of these recessions were in a central incisor position, and none of them had been treated with a connective tissue graft. And if you look at the results, comparing the sites with the connective tissue graft on the right in the table, comparing with the patients that have not received the soft tissue augmentation on the left in the table, you see a slightly higher recession in the sites where no grafting had been performed. So concluding, they stated that there is a clear need not only for a GBR procedure when you do an immediate implant, but especially in aesthetic sites for a soft tissue grafting. Since the remodeling processes cannot be planned, you don't know where you're going to end up, and they seem to have been ongoing for the course of 5 years in this study. So this is really an important take-home message, that if you place immediate implants in order to compensate for the resorption that will happen, you will have to augment the hard and also in the aesthetic side, the soft tissues at the time of implant placement. So let's come back to this clinical case that I had started with. Can we prevent the ridge from resorbing? With placing an immediate implant, no, it cannot be prevented. We cannot prevent the resorption in general. We can help to lower the resorption, but we cannot prevent it in total. So let's have a look at some ridge preservation procedures. Here in this case, you see that the ridge preservation procedure has been performed with underlying a bone substitute material and then a soft tissue substitute material on top, sutured to the extraction site. So let's look at the clinical case. It's very close or very similar to this second case that I have shown you with the young girl who had lost her upper central incisors. Her upper incisors had to be extracted because of root fractures and huge inflammation. You see on the left side the teeth before extraction, and on the right side the site after extraction and after ridge preservation with a bone substitute material. Later on, a soft tissue substitute material was sutured in order to cover the sockets and then left for healing. And in the beginning it didn't look so nice, the healing, although the patient had been given antibiotics and she had to rinse with the mouth rinse with chlorhexidine in order to keep the site as clean as possible. Sometimes you also have this popcorn effect, which you can see here. After some more days of healing, even if these bone substitute particles come out, this is not a big thing. We don't remove them, we just leave it. If they come out, we let them come out, but that's totally okay. You just have to inform your patient that this can be a normal thing happening to these sites where you perform ridge preservation procedures. And on the X-ray, you do see that there is something in the alveolar. Whether this is going to be bone or not, we don't know. It's radio opaque. You can see that the alveolus has been filled with some ridge preservation material, and then a resin-bonded provisional bridge has been inserted. So this is the clinical site then of the patient with the provisional after 1 week of healing, and then this is the progression. This is then with the fixed provisional, already a much nicer healing and a very healthy site at this time. Then this is after 5 months. You see the tissues have really matured, the soft tissue has matured, and the site is quite healthy. And this is after 12 months. You can even see some slight creeping of the soft tissues So this resin-bonded provisional was a very good solution for her and did give us the time to leave the site for final healing. And this then is after 16 months, and you can see when you look at the vertical, we did not lose a lot of the ridge height. And when you look or on the previous pictures, you have also seen that at the buccal aspect, we did not lose a lot of the volume because we had performed a ridge preservation procedure in both these sites. So let's look whether this is really something to go, whether we do have data for ridge preservation procedure, or whether this was just some lucky punch in one of the clinical cases. Avila Ortiz and co-workers have done a systematic review and a meta-analysis on alveolar ridge preservations. And they have been able to gather a lot of data because there is a lot of evidence available. They have done a literature search and have only included RCTs. And they have looked at a lot of different ridge preservation procedures, different materials and different methods at performing ARP. They did screen more than 3,000 articles, and they could include 25 articles, 22 RCTs, and 9 different ridge preservation procedure approaches. They could not determine a superior ridge preservation procedure, but the application of a particular xenogenic or allogenic material covered with an absorbable collagen membrane is associated with was associated with the most favorable outcomes in terms of horizontal ridge preservation. So it is really important that you not only do a ridge preservation procedure in the alveolus, but it's also important that the ridge preservation of the alveolus is being covered, because there we don't have any soft tissue anymore at the time of tooth extraction. So it's called the socket seal. So the seal also has to be socket. The socket also has to be sealed. That could really be shown in this systematic review. So they concluded that alveolar ridge preservation with the socket seal is an effective therapy to attenuate the dimensional reduction of the alveolar ridge that would normally take place after tooth extraction. And what is really important and what I would like to stress out for this systematic review, that we have a really very high evidence level. The meta-analysis could be performed on the basis of 14 RCTs, and the strength of the statement therefore is high. So this is really important, I think, for us to know that the data is really very good and the evidence level is very high for this type of intervention at the time of tooth extraction. Then some practical implications is that tooth extraction should be performed minimally invasive, so it should be performed flapless, and it should be taken care that the alveolus can be left intact in order to minimize alveolar ridge reduction. Let's look at the effectiveness and clinical performance of early implant placement. This would be type 2 after 4 to 8 weeks compared to a type 3 implant placement after 12 to 16 weeks. Also a systematic review, and the main outcome when searching for data was the implant survival. It's the same as the systematic or the study we looked at comparing immediate implant placement with delayed implant placement. And then they have looked at several secondary outcomes. What they could include in this systematic review was one RCT which was, though, reported in 7 articles, 2 controlled clinical trials and 3 case series. So this was really very unexpected when looking or searching for data for type 2 and type 3 implant placement. One had not expected that only so little data is really available on these types of procedures. So it was a total of 140 patients and 140 implants that could be looked at or that could be included in this systematic review. And in total, these 19 articles that could be included provided data from only 6 studies performed by 5 research groups. And the principal findings were that regarding the implant survival, for type 3, it was 95% of implant survival compared to 100% in type 4. Studies reported high values of implant survival, minimal technical and biological complications, and high aesthetic scores, both short and long term for type 2 and type 3 implant placement. But quality evaluation of the studies, as I have mentioned before, highlighted important weaknesses in the included trials, and there were not many trials, not many high-quality trials that could be included in this systematic review. So there is really only limited data on type 2 and type 3 implant placement, which was, as I said, unexpected. But it appears that both types of implant placement or timing can perform well, short and long term. However, please keep in mind that there was only a limited number of cases, only 140 patients implants, and there was a significant heterogeneity within the studies that were compared. And there was also a high risk of bias. So practical implications, you as a clinician should be aware that early placed implants can show favorable outcomes, but the limitations of the available data diminish the outcomes. So this has to really be stressed. And this can also be seen in the evidence level is only a 4 for this systematic review, and the strength of the statement is low due to the small sample size, the heterogeneity, and the risk of bias. So let's look at another systematic review on the management in general of the extraction socket and the timing of the implant placement. 4 systematic reviews have been performed in order to write this article. One on alveolar ridge preservation that we have already looked at, and one on immediate implant placement. Then the next one, there is the one we just looked at, the early and delayed implant placement, and then alveolar bone augmentation at the time of implant placement in healed ridges. So these authors have come up with 23 consensus statements. I will not read them all out to you. You can go and have them look up by yourselves in a quiet moment. And 12 specific clinical recommendations. The group emphasized that the evidence base mostly relates to single tooth extractions replacement. So there is not a lot of evidence on multiple tooth sites. This also is quite important, I think, when talking about ridge preservation procedures and timing of implant placement. So the applicability to multiple extraction sites of these data requires careful consideration. But the principal findings were that substantial and good for us expanding evidence base is available to assist us clinicians when in decision making related to the transition from a tooth extraction to its replacement with a dental implant. But as we hear all the time, also regarding this topic, more high quality research is needed in order to have better and evidence-based clinical guidelines when having to decide when to extract the tooth, what to do, and when to place the subsequent implant. So the group that has been writing these systematic reviews, they have come up with 6 considerations that should and could and can assist us clinicians in the clinical decision making. So the first would be whether there is a presence of infection. We do have clinical data then that when we have a tooth which requires extraction with an apical infection, immediate implants can be placed and they work fine. Regarding the survival of the implants, then we have to have an ability to achieve a primary implant stability when placing our implants, and we would like the implant to be in a correct restorative position. Then we have to make sure that we do an atraumatic tooth extraction. We have to check whether there is a presence of a damaged alveolus. This is quite important also when taking decisions on how to treat sites. Then we have to have a look at the periodontal phenotype. You have seen in this COSIN study, they had only included thick phenotypes patients when placing immediate implants in aesthetic site, and still they did experience midfacial recessions. So this is something quite important for us when planning these aesthetic implant cases. Then we have to check for the aesthetic demands, not only our demands, but also the patient's demands. And then last but not least, the systemic conditions of the patients. So again, I would like to look at this scheme with you, that the options that we have for implant placement. So we really have to have a plan when we have a tooth extraction imminent or planned. And then we will have to decide which of these possible ways we go, which of these treatment options is the right one to choose for our patient or our site. I will now show you this case that I had started with, this patient that came with 2 central incisors that had been restored already. One central incisor, the right one, had to be extracted due to recurring endodontic complications, and the other central incisor was planned for a new tooth-borne crown. So the tooth was extracted atraumatically, you see, also flapless. Then a ridge preservation procedure had been performed with a bone substitute material on the top and a soft tissue substitute material on the bottom. So a socket seal had also been performed along with the ridge preservation, and then a tooth-borne provisional lab site provisional was inserted, and the patient was left with chlorhexidine rinsing for 7 days. And on the left side, you see the clinical pictures at the time of suture removal. You see a very, very nice healing. You see some fibrin, but a very uneventful and non-infectious healing. Then at 18 days and at 60 days, you see both from the buccal and from the occlusal that I was able to keep almost all of the ridge contour to the original. And it's really nice in this case, we can compare it with the contralateral central incisor. This is at the time of implant placement. You see also after flap elevation, there is really a nice bony contour. There is a bit of vertical defect. So a bit of bone was lost, of a bit of hard tissue dimension was lost to resorption, but still a very nice situation for placing an implant. Then the implant was placed with a guide, with a surgical guide, and for resorption purposes, an additional GBR procedure was then performed at the time of implant placement. Later on, after healing of the implant site, an additional soft tissue augmentation procedure with a soft tissue substitute was performed in order to gain or to compensate for the slight loss of volume, of especially soft tissue volume at the buccal aspect. And then this is the sequence of healing after the additional soft tissue augmentation. Here we have the final clinical outcome, an implant-borne crown at site 1-1 and a tooth-borne crown at site 2-1. And this is the final result. And on the next slide, I show you the situation the patient did come to the practice with. So this was really the situation. Already the patient had a buccal resorption, and with this type of atraumatic tooth extraction in site 1-1 and the ridge preservation procedure and the longer healing period, we were able to come to this, I think, very aesthetic clinical outcome. And we had, in the end, a very happy patient. So the take-home messages are as follows. When you do a tooth extraction, when you have to perform a tooth extraction, or before you have to perform a tooth extraction, you need to take the right decision. And I hope I was able to give you some answers, some possibilities on how to decide, how to choose the correct treatment procedure when you have to do your next tooth extraction. Then another take-home message would be that the immediate implants cannot prevent from bone resorption. Even if you do a guided bone procedure at the time of implant placement, you will still lose up to 15 or 20% of the ridge volume. So it's not possible to prevent the ridge from resorbing when placing immediate implants. In general, there is a higher risk of early implant loss when placing immediate implants, with up to 4% more implant loss. All were early implant losses when compared to delayed implant placement, so type 3 implant placement. So when you decide to go for an immediate implant, you always have to make sure that the benefits of placing an immediate implant outweighs the risk that you take in early implant loss. And what was the most astonishing, I think, when looking at the data, at the clinical data, is that we only have limited evidence for type 3 and type 2 implant placement, and we only have 140 patients or 140 implants that these results that we have are based upon, and that the level of evidence is really very low for these type of implant timing and implant placement. Again, I leave you with this scheme of the options that you have when doing a tooth extraction and when planning an implant placement later on. And I thank you very much for your kind attention. It was a privilege and a pleasure for me to being able to take part in this webinar tour, and I thank you very much, and I hope there's going to be some questions later on and discussions. Thank you.